Put both hands flat on the table. One of them no longer looks like it belongs to you. The skin across the knuckles is glossy and stretched. The color drifts through the day, mottled and dusky by morning, blotched red by evening. It is colder than the other hand, and you can prove that with a thermometer, and a bedsheet dragged across that skin registers as a burn. Or there is nothing visible at all. Something happened to you. Combat, an assault, a highway collision, and your body never stood down. Your resting heart rate will not settle. You sleep in fragments. A car door closing 3 houses away puts you on the ceiling. I am an interventional pain physician. Let me show you what is actually happening. At the Padda Institute Center for Interventional Pain Management in St. Louis. Both of those patients get referred to me for the same injection into the front of the neck. And both have usually already been failed the same way. The first arrives having had 3, 4, 5 stellate ganglion blocks, and not one line in the chart records whether the sympathetic chain was ever actually blocked. No eyelid noted, no hand temperature before and after. A needle went into a neck, and the encounter generated no information at all. That is not a diagnostic test. That is a billing event with a needle attached. The second walks into a storefront, selling this block as a nervous system reset. Cash up front, package of 3, no mental health clinician in the building. That is not medicine either. Understand what this structure actually is, because its reputation misleads people. The stellate ganglion is not a sensory nerve. It is the fused cervicothoracic sympathetic ganglion, seated at the transverse process of the 7th cervical vertebra, near the neck of the first rib. It is the relay station for sympathetic outflow to the head, the neck, the upper limb, and the heart. It carries no pain fibers from your hand. So why block it for a burning hand? Because of sympathetically maintained pain. In animal models of nerve injury, injured pain fibers begin expressing alpha-1 adrenergic receptors on their surface. Once those receptors appear, norepinephrine directly excites the very fibers that report damage. I want to be exact. That is the leading proposed explanation. It is not proven in humans, and anyone who states it as fact has walked past the data. The second mechanism is visible to the eye. Sustained sympathetic vasoconstriction clamps down the small vessels of the hand. That is the cold, mottled, swollen limb of complex regional pain syndrome. Perfusion falling at the moment inflamed tissue demands more of it, which is why the differential has to be settled before a needle is ever opened. A burning arm is not a diagnosis. It is a complaint with at least 5 plausible authors. Cervical radiculopathy at the 6th or 7th root follows a dermatome, reproduces with a Sperling maneuver, and declares itself on electrodiagnostic study. Thoracic outlet syndrome is positional, provoked by arm elevation. Peripheral polyneuropathy is bilateral and stocking glove, and here it is frequently driven by hyperinsulinemia. No sympathetic block corrects that, and reaching for one instead of a fasting insulin is malpractice by omission. Post-herpetic neuralgia sits in one dermatome and carries a shingles history you have to ask for. Every one of those has been injected in the neck by somebody who never sorted them out, and when the injection did nothing, the patient was blamed for being difficult. The needle target is not the ganglion. It is the Chassaignac tubercle, the anterior tubercle of the 6th cervical transverse process, one full level above the structure we intend to block. Anesthetic is deposited deep to the prevertebral fascia over the longus colli and allowed to spread downward along that plane. We go high on purpose. Lower down, the vertebral artery lies exposed and the dome of the lung is close. That level buys margin, and margin is the whole game in the front of the neck. Ultrasound is not a luxury here. The landmark technique had you palpate the tubercle, push the carotid aside, and inject into anatomy you could not see. Under ultrasound, I see the carotid, the vertebral artery, the thyroid, the esophagus, and the longus colli, and I watch the needle tip advance into the layer I intend. Then I prove it worked, which is what separates a diagnostic block from a ritual. Adequate blockade announces itself objectively. The eyelid droops and the pupil constricts. Horner syndrome. The eye reddens. The skin temperature of that hand rises measurably, documented before and after. Those signs are the receipt. And here is the reasoning that receipt makes possible. If sympatholysis is documented and your pain is unchanged, sympathetically maintained pain becomes far less likely, and the plan changes that day. That is a useful answer, not a failure. I will not repeat an injection that has told me it is the wrong lever. One caution: an incomplete block can produce a false negative, and fibers of Kuntz can bypass the ganglion. A negative result gets interpreted, not obeyed. You deserve this evidence unvarnished. For complex regional pain syndrome, the Cochrane Review by O'Connell and colleagues in 2016 pooled 12 studies and 461 participants, rated the evidence low to very low quality, and concluded that the limited data do not suggest sympathetic blockade relieves pain. That search closed in 2015, a decade old and thin. So here I use the block primarily as a diagnostic instrument and as an adjunct that opens a window for the work that rebuilds a limb: desensitization, graded motor imagery, mirror therapy, progressive loading. It is the anesthetic for the rehabilitation, not the rehabilitation. For post-traumatic stress, the randomized sham-controlled trial by Ray Olmsted and colleagues in JAMA Psychiatry in 2020 enrolled 113 active duty service members, 80% meeting full criteria, at mild to moderate severity, 2 right-sided blocks at week 0 and week 2. By 8 weeks, symptom scores had fallen 12.6 points against 6.1 with sham. That difference is real and modest, and the authors concluded only that the block merits further trials as an adjunct. I say it plainly: off-label, investigational, alongside trauma-focused therapy and medication, never instead of them. The risks come from Gowell and colleagues in regional anesthesia and pain medicine in 2019, who cataloged 260 adverse event cases: common and temporary, hoarseness, difficulty swallowing, a heavy eyelid, hours, not days; rare and serious, seizure from intravascular injection, hematoma causing airway obstruction including 1 reported death, and cervical epidural abscess including 1 reported case of quadriplegia. I never block both sides in one session, because blocking both recurrent laryngeal nerves can compromise an airway, and the benefit of a single block is measured in weeks, not years. What I am about to describe is a composite, a picture assembled from many patients with this condition, not one person's chart. A patient arrives months after a wrist fracture that healed cleanly on film. The bone is fine, the hand is not. It is cold, swollen, glossy, and so sensitive that a shirt cuff is intolerable. The arm hangs unused. The shoulder is stiffening. First block: Horner syndrome within minutes, hand temperature up several degrees, pain dropping sharply for 4 days, not forever. That window told us the sympathetic contribution was real and that it was not the whole disease. The hard part came afterward. We timed a short series of blocks so each covered a therapy session. The point was never the injection. It was getting that hand to tolerate being used. The worst day was the day the therapist asked for weight through a burning palm. Between visits, we worked the terrain that keeps a nervous system sensitized, wrecked sleep, and a fasting insulin nobody had ever checked. Nutrition moved toward whole anti-inflammatory food. Pro-resolving lipid mediators and near-infrared light were discussed honestly, adjunctive and emerging, not standard of care. Months later, that hand does most of what a hand should do. Color has largely normalized. Cold weather still bites and probably always will. That is a real outcome. I will not dress it up into a cure. If your hand burns and runs cold, or your nervous system has never come down from what happened to you, bring the question to someone who will measure the answer. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. The full explanation is on painmd.tv under Stellate Ganglion block. And whoever performs it, ask for one thing before you leave: the temperature of that hand before and after. And if nobody measured it, nobody learned anything. If something in this changed how you understand your own pain, that was the point. Bring us your imaging, your history, and your questions. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Everything in this video is education, not medical advice. Ask for the diagnosis before you accept the procedure.